Hello, it's Mark Kris from Memorial Sloan Kettering. I'd like to speak today about a recently published group of consensus guidelines in the Journal of Thoracic Oncology. In the article by Spicer, there is the report of consensus guidelines from IASLC by an international multi-specialty panel trying to highlight areas of agreement as to principles of therapy for people with surgery that are going to be receiving either pre or postoperative therapies. There's neoadjuvant and adjuvant sections there. These guidelines are very special in that they not only reflect a multidisciplinary panel, but an international panel. As those of you that have worked in this space realize that there are very different approaches to diseases, some based on experience and some based on the regulatory environment in the various countries of the world. So they're a unique guideline panel. I'm not going to go through every one. I encourage you to read that, those of you that work in this space. But I do want to highlight a couple of them and the reasons behind that. The first is that that for the surgical evaluation, it should be done by a thoracic surgeon. I think for these complex cases where the surgery is often technically more difficult because of the more advanced stages, you need a thoracic surgeon. And I know that's not always the case, but I think particularly in these cases of locally advanced disease that are going to be receiving adjuvant and neoadjuvant therapy, a thoracic surgeon should see them. Also, the thoracic surgeon determines both operability, and that is medical fitness, and resectability, and that is the likelihood of an R0 resection. Both need to be determined, both by a thoracic surgeon. A second consensus statement is that you need to do molecular testing, ideally comprehensive. However, at a minimum, you need EGFR and ALK. It's part of the label for the use of neoadjuvant chemotherapy and checkpoint inhibitor. And now that we have adjuvant osimertinib, adjuvant alectinib, you need to know that as well. So you need molecular testing. And I can't emphasize enough that every patient needs comprehensive molecular testing at the time of diagnosis. We'll talk more about this at a later talk. A couple other guidelines worth mentioning. That for stage 3A, and I'm going to quote here, neoadjuvant chemoimmunotherapy is strongly preferred to upfront surgery for medically operable patients with resectable stage 3A disease. So a clear preference by this international panel for chemoimmunotherapy for stage 3A. It's another one that I think is worth talking about. Following neoadjuvant chemoimmunotherapy, invasive mediastinal restaging is not routinely required. I think many individuals and centers suggest doing a restaging invasive procedure, and truly, if a patient has received neoadjuvant therapy, they're otherwise fit, no progression is found, they should move on to surgery. And that's another guideline panel too. And that unless there is clear-cut progression or the attending surgeon would say that surgery is no longer feasible, you proceed no matter what the findings are on imaging studies. Now, there was one area in neoadjuvant where there was no consensus. And actually, consensus means 85% agreement of this international panel. And it's actually a very strong recommendation to do that. And this is what to do with patients with stage 2 disease. The majority of folks, 65% of them said these patients too should get chemoimmunotherapy, but it was only 65% not the 85 that would be required to say that there is consensus. I think many folks felt that there are certain patients with clinical stage 2 disease where upfront surgery would be more preferred. However, the data would say that these patients are like stage 3A, and they should get neoadjuvant therapy. In the adjuvant situation, what they added recently that people needed testing. People with EGFR should get osimertinib. People with ALK should get alectinib. The one thing they added in the ALK space is that adjuvant chemotherapy prior to alectinib can be considered at the discretion of the providers. I think many people on the panel felt that the trial that was done, because it did not include chemotherapy, did not address the current standard of care, and that chemotherapy should be considered, even though that pivotal clinical trial that led to the approval of alectinib in the adjuvant space did not include chemotherapy. I think the majority of people there said they would still recommend chemotherapy in a patient that was to receive it. So I urge you to read these guideline statements. It's very hard to come to consensus, particularly an international consensus. And consensus here meant basically 9 out of 10 experts in this field from across the world agreed on these. I think it's amazing that we had this much agreement. I urge you to use these and to take these recent advances into your clinic and to use them for the care of your patients.